It is my pleasure to introduce Dr. Alex Means, who practices general dermatology in northeastern Wisconsin as part of the Advocate Health System, where he serves in both the larger medical group's governing council and his local management committee. He also holds an academic appointment at the Medical College of Wisconsin since 2018 and is the president-elect of the Wisconsin Dermatological Society. His work in asylum medicine began in 2016, and we're very excited to have him here talking to us about the role of dermatology and dermatologists in asylum medicine. So over to you, Dr. Means.
Thank you so much. I am going to just hastily share my screen and hopefully, please let me know if there are any challenges. Seeing this in full screen, just give it a minute because life. Is this working okay? Okay.
Yes.
Please, at any point, let me know if any problems. But again, I just want to thank everyone for this invitation. I'm so excited to be here. This is a topic very near and dear to my heart. I'll attempt to inject some levity, but it's just a really dry and kind of hard topic to go through. One disclosure, I have volunteered as a medical examiner for asylum cases on behalf of Physicians for Human Rights, but I don't take compensation for them. I am not a board member, and I don't know anything about their other humanitarian policies or stances and other issues, only this particular context. I also feel it worth saying I'm not a lawyer, but certainly this field necessarily deals with a lot of legal issues. And so I'll do the best I can to kind of break those down in a way that's understandable for us. This presentation will discuss forms of torture and ill treatment, as well as their cutaneous sequelae. So I really do feel a need to impart a serious trigger warning. So please, I won't take it personally. You can turn the video off, you can turn the audio off, but it's necessarily kind of a tough subject. The agenda, again, I'll try to follow a 30 to 40 minute cadence so that we have some time for questions at the end. Terminology necessarily going to be dry, going to be kind of boring, but we got to get through it. The legal aspects of asylum medicine are really important to understand before we get in too much about the role of clinicians and the importance of the skin in asylum evaluation. And then I'll end with just some current trends in asylum seeking, both in the United States, but also globally. So I cannot give a Yale Global Health lecture without some sort of homage to Dr. Aisha Sethi, who is this lovely human being in the middle who totally changed my career trajectory. When I was a medical student, I attended a conference on tropical dermatology that she had given, where she referenced going to Malawi and working with patients with albinism. I was really interested, and for 3 years, I was like, this is the only thing I want to do in my life. I'm going to do it. I had already decided I wanted to do dermatology, but I was just like, I want to do some sort of global dermatology and some sort of tropical dermatology if I can. I included this photo here because I think she just looks like Superman with a cape, just saving the day, which is kind of how she always is, just always in the process of some really important action. You'll see at the beginning of this experience, I'm really happy, I'm really excited. This is our Albinism Awareness Day. This is actually Dr. Schmaltz at Brigham, who is really involved in squamous cell research, but was also kindly attending this Albinism Awareness Day with us and imparting kind of her perspective and experience. That was just, it was a really wonderful trip until midway through the day, I started to get a little bit of food poisoning. At first, I wasn't sure if it was malaria. You know, everyone else is having a great time. This dermatologist here is another just wonderful dermatologist, Dr. Una Miniter, who practices in kind of rural Illinois and still has special expertise and interest in tropical dermatology and is a dear friend like Dr. Sethi. But then, yes, by the end, I was pretty much 103.2, constantly running to the bathroom. My memories after about 3 p.m. are non-existent. So I just trust everyone else to kind of tell me about the experience. We went to refugee camps, and I realized that a lot of the refugees in Malawi are patients with albinism from neighboring Tanzania, where they were being persecuted for kind of archaic shamanistic practices. So there were all these antiquated beliefs that if you raped an albino, you would be cured of HIV, or if you cut off their limb and baked it into a pot or a pot of soup, then you might be cured of cancer. Or if you scalped a living patient with albinism and wove their hair into a net, you would get a bigger fishing catch. So they've made some good progress since then. The work is not over. But you can just see kind of looking around the room, there are so many patients with albinism. And it was really, really powerful for everyone to kind of come together in that space. Tragically, to illustrate the plight of patients with albinism in East Africa, there was a bus that actually ran over a patient walking to this event and left them dead on the side of the road the day of. So that was kind of heartbreaking, but again, really ignited a spark in kind of global health and certainly an interest in refugee and asylum medicine in me at that time. There is actually a second follow-up to that story. So after I finished my residency, my first job out of Chicago, the University of Chicago, where I did my training, was at Brown. And so it was a hop, skip, and a jump from New Haven. There was an asylum training being held by Dr. McKinsey, who's over here on the right. I don't know how many people are familiar with her, but she actually is the head of the asylum center at Yale, which is one of the largest asylum centers in the country. So anyone from New England, you have a wonderful resource in your backyard. There's also asylum centers at Boston University, I believe, Georgetown, Los Angeles. So they're kind of scattered throughout the country, but I'm not aware of many in the Midwest, just a handful. So I wanted to do my training with the person who wrote the book, and it's just really, really excellent. And so that was kind of my second Yale connection, which I felt obligated to share, mostly for brownie points. So when we move to the actual dry definition part of the webinar, it's really important to understand the difference between a refugee, an internally displaced person, and an asylee. A refugee is someone who was resettled to the United States before they came here. So they worked with the U.S. resettlement program, other kind of state and governmental agencies that we'll talk about in the next slide. These are often individuals who have a particular connection to the United States, such as Afghanistan. And again, we'll talk about these kind of categories of persecution that give them the ability to make a case to come to the United States. And they, most importantly, have to be admissible. So we are not accepting people who are known terrorists who have tried to overthrow the government. I think that's kind of in the news a lot, but these are just normal people trying to make a living who, for whatever reason, are not able to do so in their home country. An internally displaced person is someone who meets the definition of a refugee, but they are still remaining within their own country and have never crossed an international border. So if you think about a lot of what's happening in Palestine currently, these individuals clearly cannot still live in Gaza, but they're also not able to go to Egypt. They're not able to go to Lebanon. So they would be kind of internally displaced people. When we think about an asylee, it's someone who meets the definition of a refugee, but they are already in the United States or the country in question, and they're seeking special protected status, or they're presenting to, for example, the US-Mexico border and seeking admission at a port of entry. So this photo, again, busy, very tough. I'm not saying anyone needs to understand all of it, but I want us to understand visually some of what was discussed in the last slide. So again, if we take a refugee and we kind of follow them through this resettlement process, they work in concert with the United Nations High Commissioner for Refugees, the Department of Homeland Security, the U.S. Department of State. They basically, once they're refugees, have a path to citizenship through obtaining a green card or permanent residence, which allows them to petition the U.S. government to bring their own family members to the U.S., get work, and basically become U.S. citizens. Someone who is seeking affirmative asylum enters on a valid visa, and then within 1 year makes a claim, files a form called a 589 to state their application for asylum. They interview with the necessary immigration individuals, and they don't have to go through the court system. There are individuals who can seek affirmative asylum at the border, but this often leads to a little bit of a different approach where they are transported either to a detention center or are turned away, depending on kind of the timing and the situation. And then finally, there's defensive asylum, where someone came here legally on a visa, but maybe overstayed or They had some other issue that now they're going through more of the courts. And as you might imagine, defensive asylum can be a little bit trickier than affirmative asylum. And we'll talk about that in some later slides. So bringing this all together, who are the individuals responsible for administrating kind of the U.S. asylum law? We have the Department of Homeland Security, which I think most of us only know from TSA, from flying, but it's actually four different branches. The first one, USCIS, is kind of the branch of asylum officers that will process these direct affirmative applications. You have, for defensive applications, ICE, which a lot of people who work in immigration kind of sends a chill down their spine, not just because of the name, but this tends to be, again, kind of the more aggressive route to go and can be a little bit more stressful, both for the lawyer and for the individuals seeking asylum. And then finally, we have Customs and Border Protection for this kind of second category of affirmative asylum processes. Not, again, not super important, but when we use these terms, I want people to at least have a high level idea of what's going on. So this is something that nobody's going to remember, I'm sure, after this talk, but asylum law is actually fairly recent. It's considered a branch of immigration law, and this was spurred in a lot of countries by World War II. So when you think about that ending in the 1940s, there were a lot of different discussions happening globally, which again are kind of coming back into the center now with the Israel-Palestine conflict. But we think about the INA as kind of the foundation of domestic immigration law. It was amended in 1980 through the Refugee Act of 1980, where formal procedures for asylum were created. And then in 1986, there were some hurdles placed for individuals trying to win asylum or withhold removal. And one of the main ones was there was this 1-year filing requirement that we talked about, where once someone decides they want to seek asylum, they have 1 year to do it, which you can imagine is really hard when you've experienced a traumatic event. You've now come to the United States. You may not speak the language. You certainly don't understand how to get a lawyer and all these other things. So it's not everyone's favorite policy, but it is what it is. And I think it's worth noting that these policies were passed by a variety of different political administrations. So this was the Clinton administration. So when we go back to that term persecution and we think about what are the categories that warrant seeking asylum or refugee status in another country, there are 5 kind of regularly used that allow an individual to plead their case. You could plead your case for other things, but the government doesn't care. So these are the 5 that really are used time and again and have kind of held up in the court systems. So you need to argue that an asylee stands a reasonable possibility, which again, in legalese means at least 10% of suffering harm if returning to their original country of origin based on race, religion, nationality, political opinion, and understandably, this is typically dissenting political views, or members of a particular social group, which in recent years has come to mean primarily LGBT, a particular tribe or clan, or a family member, because some countries, what the typically husband says goes, and if you are a member of that family, your husband has rights over everyone. So if you would be placed back in that group, you might suffer domestic violence. That's considered kind of a special social group. And again, I'm not going to go over all the nuance. I don't personally understand all the nuance, but one category that's kind of interesting is that gang affiliations are typically not included because the threat of violence in joining a gang is to essentially keep people in the gang activities. So I guess the rationale is that you know what you're signing up for, essentially. There are alternative forms of relief from deportation or removal. These do not provide the same path to citizenship. They don't provide the same kind of benefits. And most importantly, these individuals are not necessarily kept in the United States. I'm sure we could talk to Dr. Junejo and get his thoughts on the whole British Rwanda situation happening all over the world. But this does not mean you're going to be staying in the United States. It is, however, better than nothing. And certainly it's saying that, like, okay, we understand these individuals now have a more likely than not, so greater than a 50% chance of suffering persecution. It's a higher bar, but it's still a protection. There's also this Convention Against Torture Treaty that offers similar limitations as with the withholding of removal, but it provides kind of a explicit definition of torture, which I will let everyone read because it's really cumbersome and legal, but also helpful to know. Finally, there are some additional exceptions. There's particular caveats made for victims of domestic violence, typically women, victims of human trafficking or kidnapping, and then abused or neglected children. Again, going back to that special category of a family, if you have a 16-year-old child who's being abused by both their parents, you can't send them back to that country with those parents. So there are alternative paths, but they're not used regularly as one, or they're not used commonly, I should say, as one might imagine. So why should anyone who has a clinical background care about practicing asylum medicine? Well, we know there are three factors that predict success in asylum claims. One of them is obtaining legal counsel, which again goes without saying, but what isn't intuitive is that paying for representation makes your chances far worse than if you work with a firm that is doing this pro bono because they have the resources and the support of larger nonprofit organizations to do so. Part of it is volume, part of it is probably corruption, sadly. And again, what restitution do these individuals have if they're seeking asylum and someone takes all their money and then just says, good luck on your own? It also goes without saying that applying in some cities like New York is probably going to be easier than applying in a city in Texas like Houston. But I think something that I was not aware of is that having a medical evaluation by a trained professional markedly increases the likelihood of an asylee being granted asylum. And it's not like a small difference. It is 90% compared to about 37.5%. So when I heard this, I was like, okay, sign me up. I'll do as many of these as I can. So something that we understand being in healthcare is that the absence of a physical scar or some other mark does not mean that something did not happen. However, this is not always the legal system's understanding. And so we're kind of uniquely qualified to bridge that gap and provide that interpretation. One thing, though, still worth mentioning, the majority of asylees will have cutaneous scars related to their torture or ill treatment, which is more than any other physical observable organ system. So you could make the case that 100% of victims of torture or ill treatment will probably have some psychological burden, but after that, it is the skin far and away, more than joints, more than neurological symptoms, more than anything else. So our role is really important. This is kind of going to start to move into some of the visual depictions of things. So if anyone, again, is having a hard time, I don't take it personally if you need to step away from the webinar. But when you think about documenting a forensic skin exam, you want to note the presence of any general skin disease. So psoriasis, acne, vitiligo. Certainly, these can be exacerbated during a period of ill treatment. They could arise during a period of ill treatment, but they're probably not exclusively due to that period of ill treatment. You want to note any kind of pre-torture injuries or scars. So did someone have a vaccination? Did they have a motor vehicle accident? And you want to make sure, again, to kind of ascribe different lesions to self-inflicted, inflicted by someone else, accidental. You also want to note, and certainly this is most common probably in Africa, but any tribal scarification. So these are examples of kind of gender-based scarification in South Sudan, where individuals in A tend to orient their scars horizontally as opposed to kind of this fan-like pattern in B. And then in Ethiopia, similarly, a little bit of a different pattern for both male and female members of various tribes and clans. In terms of specific forms of torture, blunt trauma is overwhelmingly the most common type, but as we all know from bumping into a table or scraping our knee, it doesn't always leave scars, in contrast with burns, which are far and away the most likely to leave permanent scars, although they are less common than blunt trauma. Electrical shocks, we all can imagine the burns that are sustained from them, but I think it wasn't until I started doing this work that I realized the greater morbidity comes from muscle contractures. So if you imagine someone's scrotum has one electrode and their toe has another, the scrotum is going to feel excruciating pain, but the legs and the feet are going to contract. And so there've now also kind of tragically been more sophisticated ways to torture people with electrical shocks by spreading the electrical current entrance point using gels and water that, again, for some individuals, they'll employ to decrease the likelihood of leaving a scar. Dental torture, kind of common sense, but may be masked by a lack of dental care during that period where all the teeth fall out. So the one or two that were pulled may not be discernible anymore. Asphyxiation is becoming more common. It's kind of a preferred torture method because it rarely leaves scars and the physical recovery is very rapid, but it is psychologically devastating and it is physically terrible. The term has become so common in Latin America that it's referred to as submarino, and they have waterboarding or kind of wet submarinos. Sometimes they'll use urine, sometimes they'll use other fetid water sources, but they also have dry submarino where they'll use dirt or plastic bags or things like that to asphyxiate people. There's also kind of intuitively incisive and penetrating trauma. We understand this, I think, pretty easily just living in the United States, but I was not aware that sometimes people will intentionally also rub substances like hot peppers to increase the likelihood of creating painful and itchy scars just because that's part of torture. And by the way, when I say torture and ill treatment, I should have clarified earlier. I'm not aware of really great legal definitions between them. They're kind of used in the medical community, I think, a little more. But to me, torture is there's an intent. So you're harming a person with the intent of either extracting information or confession or something. Ill treatment is just you are a masochist. So again, that might be oversimplifying things, but when I use those terms, I want people to at least understand where they're coming from. Some other forms of torture, head trauma, it's important to realize that if someone is falling, they are hitting the ground with one part of their skull, but their brain will move in the opposite direction because of inertia. So the injury is actually opposite where the discernible bruise or hematoma might be. Positional trauma, kind of like asphyxiation, becoming much more common because it does not usually leave scars, but is extraordinarily unpleasant. This is frequently combined with something called phalango, which I included a picture of. This is where the feet, usually more than the hands, are kind of whipped or beaten with blunt instruments like batons. One, because the feet and hands tend to heal really well. Two, because it's extremely painful because people have to walk. These are some Kodachromes. This is a dermatology lecture, so I'm not letting anyone get away without some Kodachromes. But plastic burns. You can see the two kind of hyperpigmented patches or possibly even thin plaques where the burn occurred. This is an ember burn where we can kind of see maybe where the embers were applied, but the skin got infected because this individual was obviously not kept in the most sanitary of conditions. And so the scar ends up being a little bit larger. This, you can see where two probes were placed for electric shocks to run a current through. But I want to point out a third area of involvement because I think this goes to what we were talking about earlier with pre-existing conditions. This is tinea versicolor. But if you don't have that knowledge and that training and that kind of dermatologic background, you might misattribute that to the burn. But careful examination will show that this isn't quite as atrophic. These are cigarette burns. I think many of us kind of grew up with some sort of stupid Zippo challenge or cigarette challenge where we would burn our arms in 6th or 7th grade. At least my idiot friends did. I never did, thank you. But this is a stab wound on the knee. These are linear knife cuts. They're very precise. They're very almost strategic, as opposed to a knife laceration, which is a little more messy, a little more ragged, probably not done with the same degree of precision. Maybe the asylee in this picture was struggling or something like that, as opposed to restrained. And then this is a good example of rope burns. So anyone looking at this, they might be like, oh, cutting, or you burned yourself making some cookies, but actually the distribution is a little more on the dorsal aspect of the arm rather than the volar aspect. And again, with the patient's history, or the asylee's history, sorry, I'm trying not to use the word patient, you would be able to deduce that. So this kind of next series of slides is where I think we add the most value as healthcare clinicians and specifically dermatologists. So again, if anyone is feeling triggered, that's totally fine. But if people were having their cameras off, this might be a good time to put it back on because these are some really, I think, helpful terms and codichrome. So when we say in a legal context that a wound or a scar is diagnostic of something, we are saying nothing else will look like that. There is only one choice, and it is what presumably the asylee is saying. So in this case, you can see the muzzle and the flash from where the gun was held to the individual's temple. And you can see fragments of the bullet. You can see a bullet coming out of the skin here. Nothing else is going to put a bullet in the skin other than a gunshot. These are a little bit trickier. Some people would argue, okay, maybe this looks like a belt. Maybe there's some other things that can look like it. But the unevenness of the bite and the kind of differing degrees of necrosis, I don't know. To me, this looks like a bite mark, but I'll accept a little bit of ambiguity there. When we talk about something that is typical of XYZ, now we're saying there's a little more of a differential. It's not a broad differential. If we look at the stab wound, maybe without the asylee history, we might think it's a ruptured cyst or a dehisced surgical wound, but there are not too many things that are going to give you that kind of a pattern. I think it's interesting here. There's incidentally kind of a linear ecchymosis with central pallor from the blunt trauma where the baton or the club or the cane or whatever was struck across the individual's abdomen. You're not going to see the bruise at the site of impact. You're going to see the bruise peripheral to where the instrument was struck because it's pushing and compressing the blood out into the periphery. So this is kind of a characteristic tram line or rail-like bruise that you see from blunt trauma. When we say something is highly consistent with, again, it's less specific than typical of, which is less specific than diagnostic of. So this is periorbital petechiae or purpura. Any dermatologist in the room is going to immediately think of either amyloidosis or myeloma or some type of gammopathy. But you could, in theory, have a clotting disorder, an infectious disorder, if we didn't have the history that this was a stable patient, if we thought they were febrile or something. On your board exam, this can be anything. So I'd say it's highly consistent with, but the differential is still pretty limited. When we say something is consistent with, okay, now it's grand rounds, you're just throwing out whatever you can, really esoteric. This certainly, with history, would be consistent with, I think, a scald injury, especially when you kind of look at this individual's hand and you see that multiple digits are kind of in this splash distribution, a little bit more edematous. But if you're just looking at these kind of tense bullae, you wouldn't think twice about calling it pemphigoid, linear IgA, bullous lupus, a bullous arthropod, or even something factitial. When something is not consistent with, it is not consistent with. So there is nothing that's going to look like this after 4 years other than recent regular trauma. So again, I don't think the majority of asylees are trying to fake trauma histories, but I suppose it could happen. And so if something is just absolutely not consistent with what you're being told, you would document that. And again, you're not making these decisions, you're just providing information. So with respect to the commitment, after you've completed a clinical interview and you're documenting things, you start every affidavit with an attestation of your educational professional qualifications. And again, if you are any type of physician in any specialty, you are qualified to do a psychological evaluation, a physical evaluation. If you're a dermatologist, great, maybe you're better at the skin than with the cardiovascular system, but we all know how to use a stethoscope. We all know how to listen to lungs. I mean, this is, I think we, in the medical legal space, in terms of malpractice, often worry a little bit too much about, are we qualified enough? But this is the legal kind of asylum system, and a judge is just going to be impressed that you're a physician or a clinical psychologist or a social worker obtaining a psychological trauma history. So I think there is certainly a role for everyone. I, as a male examiner, do not do any female kind of genital exams. So I know some people would argue that that falls within the context of the skin. I'm very purposely not talking about that because I'm understandably usually examining these patients either alone or with one other chaperone, and extremely re-traumatizing to kind of go over those histories. So I think it's just preferred to have a same or a, sorry, a sex concordant examiner. However, you may have a male patient who was raped by multiple men. And so he might actually request and prefer a female examiner. So you have to be sensitive to these things. And usually you'll get guidance from the lawyer or the nonprofit agency like Physicians for Human Rights or whoever is reaching out for your assistance on the asylee's behalf. One thing that I think is also interesting to note is you need to take a really detailed history of accidents prior to the period of abduction. That's the only difference between this and any third year HPI history that you might take as a medical student. But really, we all know how to do this. So kind of segueing and ending into current trends globally, the majority of individuals who are falling within any category of seeking asylum or refugee status, they're almost, I think, 60% now internally displaced persons. So asylum seekers are really just this tiny black sliver in the top of this 2022 bar graph. So really, it's not the majority of individuals, but it's an area where we can specifically intervene. I can't do anything for an internally displaced person in another country. I can help someone who's in the United States who's seeking asylum if they're interested. This is kind of a recent graph looking at the distribution of individuals both seeking asylum and then being granted asylum. So again, I think in the United States, we have kind of an America-centric view where we just assume everyone seeking asylum is from South America or Central America, and everyone's trying to come to the border, and that's always in the news. We are far and away the smallest part of this problem. So most individuals, if you look, are sub-Saharan Africa and Asia and the Pacific. I think it's important to remember that the Middle East is West Asia. So I think some of those numbers are from that, but certainly other parts of Asia like Myanmar, India, Pakistan, Afghanistan, like it's just a much larger problem than we realize. And I think it's also important to realize that most of these people seeking asylum or other assistance are going to neighboring countries, with the exception of Europe, which does seem to take in more than they have originating. But again, that's a entire political discussion of itself. So this number in the United States has dropped during the pandemic. Officially, it was the pandemic. We didn't want to be admitting people with COVID who might present a health concern. You might say we're 3 years out of the pandemic. Are the numbers picking up? I think they are slightly. Um, I don't think that it's where we would expect it would be given the current administration. So another thing that was surprising to me about the asylum patterns in the United States when I started doing this work, I think again, when we think about the Latin America connection, China, far and away, both affirmative and defensive asylee applications are coming from China. So right now, there are over 1.3 million asylum applications pending. This has really ballooned since the late 2000 teens. The average asylum case in immigration court will take over 4 years, and the average asylum application, I think, is between 3 to 5. So really, really long, really inconvenient. Some of the asylum processes are really tied closely to resettlement camps for refugees. And again, I'm not an expert in this, but I'm sure there are lawyers out there who are. So we reached a historical low in 2021. So now the cap has been increased, but you'll notice that we're still not quite at that same number. We're still processing, I believe, around maybe 40 to 50,000 asylees a year. So still a little bit of work to do. And again, I'm not sure if the refugee cap and the asylee cap are the same, but my understanding is they're similar, but I could totally be mistaken there, and I apologize if so. So yeah, at this point, I just want to thank everyone for their attention. I'm happy to take any questions. Really grateful for everyone's interest. I know this is a tough topic and there's just no way to make it less difficult. So yeah, thank you.
Thank you so much, Dr. Means, for that incredibly useful but also harrowing talk. But I think it's important for us to recognize that these things are happening. Um, so, I mean, I guess we could start off the questions. We've got a few from Dr. Dempsey. So, um, first of all, can you speak about the challenges you've faced in pursuing this work?
So honestly, the toughest challenge has been getting kind of organizational buy-in. So you can't book these 3-hour history and exams in a clinic slot, but you also can't necessarily request that your organization keep paid staff on from like 5 to 8 p.m. on a Tuesday night to do it. But you don't want to invite this individual to your home because that might create a power dynamic that they're not comfortable with. You probably don't want to necessarily go to that individual's home because maybe for whatever legal reason they don't have stable housing and they're kind of nervous that you might report it. So a lot of times I'll use either the lawyer's office. I'll create kind of a like a mutual third party space where we use like an unused clinic room on a day where maybe a clinician isn't around. But so that has been a huge challenge. I think another challenge has just been the volume of cases has decreased. I was doing kind of around one a year before COVID began, and I haven't done any in 2.5 years because it's just like I said, the volume isn't there. And I think part of that is I'm in Wisconsin. I think part of it is probably the demographics are shifting. And so a lot of the individuals seeking asylum are for maybe something like female genital mutilation or females with domestic violence, and they prefer female examiners. But I've examined both male and female asylees. And um, again, you always just kind of clarify, are they comfortable with a trainee or a learner? Are they comfortable with a chaperone? Do they prefer no one? I mean, sometimes you have to interrupt the interview. It's a lot to revisit these periods of confinement and torture. And so sometimes you split it over 2 days, but really I think the hardest part is just the numbers aren't there and the volume is really going down for kind of complicated political reasons.
Yeah. And why do you think that individuals that have a medical examination are more likely to have a positive outcome in terms of asylum? Is it the documentation of torture or maltreatment, or is it something more?
That's an excellent question. I think it's our interpretation of that patient's history, right? So if you think about even our medical and clinical training, I mean, someone is going on for 10 minutes about their rash or their headache or whatever, and we have 20 seconds to kind of summarize that to our attending as we run between rooms. And so I think we're just really good at kind of piecemealing the crucial parts and kind of explaining them in ways that are easy to understand at a sixth grade reading level. I think there's a lot of misunderstanding that if again, an individual doesn't have a scar, well, then they didn't suffer the torture that they're claiming. And we can certainly speak to that and help people understand that that's sometimes possible. I think it's also with respect to psychology. So if someone is tortured, they might, as a protective mechanism, block out that period of time. Their body is shielding them from those memories. But I think sometimes judges and ICE officers might be like, well, what do you mean you don't remember this? This was the worst experience of your life. How can you not remember it? My wife remembers being in labor for 19 hours. She reminds me every month, like, so I think we can bridge that gap. And I think that's kind of where our value is really what leads to that differential.
And everyone doesn't have a medical evaluation, right? And so what determines whether or not someone gets one?
I think it depends on if the lawyer who or whoever is helping that person's case or the officer thinks it will be helpful. So yeah, I think it's really a minority. I believe I'm not remembering the number probably perfectly, but I believe like, for 5 years, 2006 to 2010, Physicians for Human Rights did less than 2,000 evals. I'm sure the numbers are even smaller because of the current kind of political landscape. So I think it's really individuals where there's some question about like, okay, are they really going to be persecuted if they return to their country of origin? And is there some documentation or some physical proof or some
Mm.
psychological proof that can show that? But yeah, I'm not entirely sure because I'm not privy to that side of things, but
Yeah.
that's what I would imagine.
Great, thank you. And we've got one question in the Q&A. They say,
Sure.
thank you so much for your lecture. As an asylee myself, this lecture really validated an experience that people rarely see, let alone understand. As medical students, what can we do? How can we better quantify the healthcare burden asylees deal with? Also, is there any way we can contact you for further discussion or ideas?
So I'll answer those in reverse. I'm always happy for anyone to reaching out to me. And I've been surprised sometimes at some of my previous institutions where I've sent out broadly to medical students and trainees, and I've been like, does anyone want to accompany me on this thing? The asylee is very open to having observers, and it's like cricket. So no, I want to support anyone in any capacity. Feel free to reach me out anytime. I guess the easiest thing to do would be to I can reply to your message and get you my email, or Dr. Janejo, if you
I
wouldn't
can
mind
send it
doing
over.
it. Yeah, but I think the second thing would be look into asylum training offerings at those different asylum centers throughout the United States. So again, um, Yale, Boston University, I think it's like UCLA or maybe USC. These are held kind of throughout the country at different points throughout the year. You go, it's usually either a full day or even sometimes a full weekend, and you kind of get additional training in those legal documentation aspects. And then you also get connected with these organizations like Physicians for Human Rights and other nonprofits that are doing this sort of work, and they can get you plugged in. But no, I always will champion anyone's interest. And I think personally, I've noted that more of the people doing this sort of work are probably in the primary care arenas. I think socially and maybe politically, it's more of an emphasis in some of their curricula than maybe in dermatology or some of the specialties. But I think there's a role for anyone, regardless of your training. And like I said, we all know how to use a stethoscope. So
Great. And we've got another question from one of our attendees. Really thankful for your talk and its timeliness. The number of internally displaced people is increasing. So are there doctors that examine internally displaced people? Do any of these reports make it to international agencies?
yeah, I'm so sorry. I actually don't know. I've only ever been in the asylum side in the United States. I would imagine, yes. I think probably organizations like Doctors Without Borders or anything like that are working with these other UNHRC organizations to facilitate some of those things. But I just personally am so sorry. I'm not able to speak with any authority.
Okay. Thank you. So, I mean, any final words of wisdom for any medical students or trainees or dermatologists wanting to pursue asylum medicine before we let you go?
No, I think again, I'm so grateful for everyone's interest. I think the only thing I would say is that we all have a lot of responsibilities and obligations on our plate. And I think everyone is kind of feeling burnt out and stressed, but this has been an activity that actually like fills my cup and really makes me excited. One, for the skill set that I have and the fact that I can put it to use. It makes me more grateful for my own life. It makes me more grateful for the resilience of these incredible people who have undergone just things I could never even fathom. And it gives me a better appreciation for the world that we live in, which is something I think we can get inured to kind of closing our eyes, but um, this really keeps them open and it just keeps you very grateful. So yeah, thank you so much for everyone's interest, and it's truly been an honor.
Thank you so much, Dr. Means. I actually have one more question. I just realized. Um, if someone has, for example, like if someone's an asylee and they have, say, you go and see them and they have psoriasis, like really bad psoriasis. I mean, they probably don't have insurance and stuff. We're talking about the United States right now. How do they get the treatment that they need? Like, are you allowed to
Yeah,
give them treatment?
I know that actually happens sometimes. So like someone will have a clear dislocation or they'll have some permanent nerve damage from a period of suspension or positional torture. And so you kind of like maybe an X-ray would be more helpful and offering some assistance to the committee or the judge or the asylum officer or whatever. So you usually, in my case, refer them to the kind of sources of charitable care in the area. So it's often academic centers, it's often centers for asylum medicine. But really, every community will have some sort of opportunity there, but it's few and far between, unfortunately, and it's often long delays. I remember in Chicago, there were free clinics that medical students from each of the major university academic institutions and universities would work at. Things like that are options, but yeah, it's tough. You have to separate yourself from the treating clinician to like, this is a forensic evaluation. I'm not here to offer any clinical treatment recommendations. And that takes some getting used to and some practice.
Yeah, I'm sure it can be quite tough.
Yeah.
Well, thank you so much for your time. And if there aren't any other questions, we will let you
All
go.
right.
It
Thank you
was
so
lovely to
much.
have you. Bye, everyone. Thank you for coming.